All right, fabulous. So now we're going to get on with the main part of the show. And we have a session now called Bold Moves in Healthcare. And there are a lot of different players, a lot of different people getting into healthcare, but perhaps the boldest move still is, can we get our data from different places? And to start off that discussion, I want to invite up to the stage the ONC Director, National Coordinator for Health IT, Don Rucker. Don, please welcome him. Why don't you grab a seat right here, and All
right, thank you.
I'll squeeze on the edge here. All right, fantastic. Okay, so TEFCA, it's changing its name. We have now the idea that there is rules, that the comments are in, the rules going to be coming. Give us the sort of state of play. Where are we in this whole idea of mediated data, mediated by providers, by patients? Where are we? Just give us a...
Yeah, so the big news here, these things take a little while to cook. But December 2016, Congress passed the 21st Century Cures Act. That act says that health data should be able to move, should not be hoarded by the folks who do it. Congress wanted new business models, transparency, consumer control, and the thing they said for this audience that is, I think, amazing is APIs, application programming interfaces without special effort. So in the modern RESTful JSON world, this is now technically possible, as we just heard, that intersection of technology and other potentials. So as part of that, we have the way Civics 101, Congress makes laws, the executive branch then puts in the details and rulemaking. So ONC, which is one of the staff divisions of Health and Human Services, along with CMS, have rules on interoperability that are, we got 2,000 comments, and we're putting them in, finalizing that to allow patients to pick apps of their choosing, authenticate them at a provider endpoint, and get their medical data. So putting it in control of the patient through that very specific mechanism.
So I would imagine, just at a wild guess, that some of those comments may come from some organizations already in healthcare. I think you saw my thing of the fortress and the battlements and storming that, who may not be, as some of our other colleagues, for instance, you might hear from Farzad Mostashari, your predecessor, or maybe Anish Chopra, that perhaps they're not always as keen as possible with some of these rulemakings. Where do you think the state of the industry is regarding this?
Yeah, yes, you're right that obviously a lot of folks, ultimately interoperability and APIs and all of this is about affordability and the economics of healthcare. If you think about it as an IT problem, that's not the way to think about it at all. A lot of people have built very non-transparent business models in healthcare, and they are wondering what that world is. DC, as you know, is full of lobbyists with theories of what that world could or should be. Interesting enough, 6 of the prior national coordinators, so 2 from GOP, 4 from the Democratic Party, have all strongly supported what we're doing here. So I think amongst the group of, let's say, IT folks who are public-facing, there's a great unanimity. In the vendor and the provider industry, folks are sorting out, where they stand. It is, as with everything else, a brave new world. You just heard a wonderful presentation.
Right. Just on that point one more time, do you think that there is much division now between the provider organizations and their vendors? Obviously, I mentioned, and Indu and I mentioned earlier in our talk, some of the major vendors. We have the Health 2.0 world, the digital health world is obviously trying to sort of glob onto that using the API frameworks, the app stores, and all the rest of it. We've also talked about new organizations coming from the outside completely as well, and some of them IPOing and looking very different from a traditional healthcare organization. How do you think they're all playing together? And again, where do you think particularly the mainstream vendors versus their customer providers are?
Yeah, there are some very specific details in the rules about payment for APIs, and consumers get it free and have some bounds, because we've at ONC heard lots of complaints about APIs are literally priced in ways to guarantee no access. I think there is a bit of a dichotomy between the people who are building these highly inward-facing delivery systems and their vendors who, where the concept is not consumer empowerment or consumer choice, it's leakage, right? The patient escaped their bounds.
The referral leakage
clutches.
issue, right?
Right.
So people sneaking out the drawer, over the portcullis.
Yes, exactly.
Away, yeah.
So, they escaped the moat type of thing with, I think more the independent primary care doctors, the independent entities, new startups with the verticals that Indu talked about. So I think that's where some of this tension is. Obviously, the one group may hold the data very much internally, and the other group has, the potential for new choices for consumers that really will feed better off data that is more freely available, where consumers can bring in their information from the entirety of their travels and existence and care. So I think there's a little bit of a tension there. There are some wins for everybody, though.
Right. One question I'm going to ask by proxy. I talked to Ryan Howells at the Care Alliance, and we can kid, because in my survey last year of API, I asked all the vendors, what the impact of the Care Alliance was. And I think 80% of them said, "Who's the Care Alliance?" But they are obviously one of the with 4 national coordinators, 3 national coordinators, and a former CTO. Health. I forget the lineup, but 4 esteemed men from government, right, in that group, pushing consumer-mediated data. Ryan had a sort of question. He says that there's in the ONC is talking about qualified health information networks. You're also talking about API endpoints. Where does the sort of the HIE fit in this world where we're talking about opening up API endpoints anyway that anybody can access, under the new rules?
Right.
How does that work together?
Well, I think there's obviously technology evolving. When you look broadly at the internet, we don't make a distinction between operation between endpoints and networks. Programmatically, from code you have to. I think it is an open issue how much individuals go to their providers, to those API endpoints, how much they use the health information exchanges. I believe a lot of what the health information exchanges will eventually morph to is on social determinants of health. Right? That broader community involvement with a lot of local resources. I've been an ER doc for 30 years in departments taking care of a lot of mental health and substance issues. So I think we haven't computerized any of that social determinant space if you really get right down to it. And they're innately local resources, whether they're group homes, they're shelters, sadly often schools, jails. So I think there's going to be a bit of a morphing of this. Certainly in the initial go-around, the HIEs will be, the collected repository of information, but that will move.
Yeah, and in fact, talking about former deputy ONC directors, Jacob Ryder up in upstate New York, has actually just built the first IPA of social determinant of health endpoints. I don't know what, I forget the term. I've interviewed him, I should know the term, but essentially doing that. And just yesterday, we had this RWAJF challenge for social determinants of health tools. There are folks in Colorado building a network, so, again, including down to, who knows about the homeless person's dog and who's going to take care of it.
Yeah, I saw that.
ER, and there's a really time to go on there. All right, so what we're going to do now is have a quick demo from another part of the federal government, very closely related to ONC, but not ONC, CMS. I'm right up on stage, Amy Gleason. Amy, where are you? Somewhere, I hope. Okay, we'll go. I do already have on stage Will Mernagh. Thank you, Amy.
Yes.
Thank you. Will Mernagh. Will is the VP of Engineering at Iora Health, which many of you know is one of the startup primary care clinics run by Rashika Fandanopoulos. I only said that because I can say his name, and I want to be proud of that fact. And Amy is these days working in the U.S. Digital Service on secondment to CMS. I hope I got that right. I'm terrible with federal titles. What she's going to show us here is a new tool doing data at the point of care, built on the Blue Button system. It's around claims data from Medicare. So, Amy, you were telling me Medicare patients see 6 to 8 providers, something like that? And
yes.
What are we doing here? What are you doing with CMS to try to improve their experience?
So I'm very excited to be here today to tell you about this new pilot project from CMS called Data at the Point of Care. As Matt was saying, most Medicare patients see about 6 or 7 different providers, and their data gets scattered across all those different health systems. And that puts a tremendous burden on the patient to remember all that information and tell their doctors over and over again. And it puts a big burden on the providers to be able to get all the accurate information they need to treat the patient. It also creates a patient safety issue because the providers may not have all the other medications or diagnoses, and an increased cost in the system for things like duplicate tests. So the Data at the Point of Care project allows providers to use APIs to request the claims information from CMS so that they can use that information for treatment at the point of care. One of the main requirements of the project is that the data has to go at the point of care for treatment purposes, and it has to go into the provider's existing workflow without adding additional workflow steps or logins to a portal. And then this information is also advancing the bulk FHIR spec standard by using standard-based APIs and getting those out into the provider world.
So Will is actually going to show this from how it works in Iora, so take it away.
So I want you to imagine that you're Dr. Will here at Iora Health, and you have a packed schedule today, and you're running behind. You open the exam room door to find Jane, a Medicare patient who is new to the area and new to Iora Health. As is typical, Dr. Will doesn't have all of her medical information, and this puts that burden on Jane to remember all of that to tell Dr. Will, and Dr. Will has to frantically work to enter all the information into the EMR. Poor Dr. Will gets so sad looking at all of the blank EMR screens. He doesn't know what medication she's taking. He doesn't know the visits she's had or procedures or diagnoses. And he has no idea the different doctors she's seen in the past. But never fear, Data at the Point of Care project is here to save the day. So when Jane made her appointment, she was actually added to Dr. Will's roster, and that happened automatically without any human intervention. And then this morning, Iora's EMR was able to request the claims data for all the patients being seen today, including Jane. So this information can help Dr. Will get a good idea of her past medical history. So first, Dr. Will can look on the medication screen, and he can see all the prescriptions that Jane has had filled, including whether they're covered or not, and he can get an idea of her fill history to see whether she's adherent with her meds. Jane had said she's taking 2 medications, but Dr. Will can actually see she's had quite a few more than 2 medications. For example, he sees she's been taking hydrocodone quite a few times, so he can talk to her about her pain and whether it's getting better or worse, whether she's having trouble taking care of herself at home. And the Iora health coaches can also use this to see if she's filling her medications and can help find out if there's new medications Dr. Will might not be aware of. Next, Dr. Will can look at the visit screen to see the medical claims that have happened. He can see visits and procedures and diagnoses for Jane. He sees here that her last primary care visit was in 2016 and that she's had quite a lot of cardiac testing done. He also can see all the providers that are associated with these visits and results. So if he needs to reach out to get clinical documentation or results from those providers, he knows where to look. And he might even choose to use FHIR because with the claims data, he also got the FHIR endpoint addresses for each of these providers, so he knows where to reach out to. And lastly, Dr. Will spends a lot of time tracking down all the preventive health items and quality measures. But with the CMS claims data, those dates are automatically filled in for him. So he can see that Jane's current on her colonoscopy and her mammogram, but that she needs a flu shot and a shingles vaccine, which he can take care of today. As you can see, Dr. Will is so much happier having all of this information. And so instead of having to frantically enter information, he can have a conversation with Jane and find out how to best treat her. After all, that's what he went to medical school for.
Thanks, Amy. Thanks, Dr. Will. I will want to point out that Dr. Will is also a VP of engineering, which is probably more complex than being a doctor. I'm kidding. Tell us a little bit about the complexity of how you've been working at Iora. It's your own, is it Chirp, I think is your own system that you guys have built?
Yeah.
Is that right? And the complexity of bringing in this is sandbox data. This isn't live and up and running yet. I'll ask Amy about what's going to happen there soon. But just give me a sense about the complexity of building it into your system.
It was relatively easy. It's the FHIR bulk standard API. We already get data like this in flat file format from our Medicare Advantage payers. So we already had places to put the data. It was really just hooking it up. It was super simple. Amy and her team were really easy to deal with. We met them down in DC. about a month ago, I think, at the Blue Button 2.0 conference, and we're excited to get involved with this. They came up to our office. We spent 2 days, hooked it up. It was really easy.
So
And it was your first example of fire, right?
It was our first time using Fire, yeah.
Fantastic. And then we talk a bit about where you are going to go regarding scaling this and taking this. Obviously, it's a great first example in the sandbox, but where's it going to go next? Where could it go? And how will this be available more generally?
Right, so providers can go to dpc.cms.gov, DPC like data at the point of care, and they can request access right now to the sandbox. So we're slowly rolling it out to provider groups like Iora one at a time, and we'll open that sandbox up probably to the larger group around the end of the month or maybe the beginning of October. And then we're going to start taking those same groups one by one into production. So we'll start with the early ones that have tested well, and we'll move a little slower with production to make sure we've got it all working fine. We'll just continue to grow from there.
All right. Amy, Will, thank you very much.
Thank you.
All right, so I'm now going to invite up to stage Ben Wanamaker, who's the head of Consumer Tech and Services at Aetna. And I would tell you that some of you who've got long memories may know that Ben was at Walmart before that. And Ash Zenooz, who has not been a health diploma before, and for many years has done, as a clinician, who's done many years in the VA and elsewhere, and elsewhere, and is the GM of Healthcare and Life Sciences at Salesforce. So Ben and Ash, if you can come on up. While they're coming, Don, let me ask you this. So I know you understand the difference between ONC and CMS and data. Right. CMS, government as payer and provider, sharing data, and government as regulator and cheerleader. Can you talk a bit about the distinction there and the difference, and what ONC's role might be with this, setting the standards for something like this?
Sure. So ONC, Office of the National Coordinator, really has been historically and is about setting of standards. And what we actually do is coordinate the private sector in setting standards for the most part. That's really the role, is facilitator. There's also obviously a regulatory role. CMS is the payer. And so CMS is taking the lead on some of the payer-facing technologies. The ONC interoperability rule is the broader economy and API. CMS has payer-specific API considerations in there. And then we're working together on some of the bigger issues around standards. And that is really largely with the private sector. There are many, many, many folks involved, probably HL7 and the FIRE group first and foremost, but there are quite a few.
And talk about the private sector. We have two of the representatives from the private sector up here. Ben doesn't live in the part of the plan, the part of Aetna which actually deals with this, but I know that private plans in the rules are also going to be moved towards the same kind of data sharing we just saw from CMS. So I would say theoretically then, you've got both providers getting access to that and eventually patients getting access to the same data from their plans. And then I assume somewhere in the middle, intermediaries helping them figure it out, which I think is kind of why I've invited Ben. One of the reasons I've invited Ben and Ash up here. So real quick, I know you two are both have got do a lot across the board in healthcare, but I want to just give you a minute or two to talk about a couple of things you're doing. So Ben, we know last year, and actually earlier this year, you announced a deal between Aetna and a small fruit company down the road here in Cupertino around this device they have I assume you have on your one on your wrist, a watch. I don't have an Apple Watch.
We can fix that.
I doubt it. I'm usually persona non grata over there. They see my cheap Android phone. But tell us a little bit about what that relationship is doing and what the intent and goal is, what you're actually doing and what the intent and goal is for Aetna members.
Yeah, we announced a product that we've developed in collaboration with Apple called Attain by Aetna. And the basic premise is you use an Apple Watch combined with a custom designed app to have a daily drumbeat of activity goals paired with machine learning driven algorithms for identifying the next best health step you could take in your life that derives from your consented sharing of your claims data and the sensor data from your device. And I think it builds on the theme that we've heard a little bit this morning, that if the past was about making money from having data, the future should be about making money from deriving value from that data on behalf of your patients. And I think Attain is a modest and encouraging first step in that. We're really excited about it so far.
So meanwhile, since you've been in Aetna, I can't remember exactly when you joined. You left the one giant Walmart to join another one. It became even bigger, right?
It did.
With a small local drugstore called CVS, right?
Yes.
While that's been going on, there's a number of other things that both Aetna, CVS, and by the way, your rivals at Walgreens and Walmart and others are all doing to try and get more involved in the direct provision of care, and so the line between what a health plan used to do and what a new entity is doing now is changing a bit. How does what Attain and what you're doing with consumers, how does that fit into that bigger picture?
Yeah, we're trying to make healthcare local, and that's in the community, in your pocket, and on your wrist. And as you get a tap on the wrist from Attain suggesting perhaps you have an unfilled med, or there might be a care visit that would benefit you, to the extent that CVS can provision that for you and make it convenient and accessible and affordable, we'll do that. So as a pharmacist who now has a panel of patients to help them manage their chronic conditions, needs tools beyond the four walls of their pharmacy box to engage with that patient, Attain can be an answer for that as well. And so we think the magic probably will happen at the intersection of that digital and physical footprint, and that CVS Health now as a combined entity with Aetna has a compelling opportunity ahead of it to make a difference there.
Ash, Salesforce has, besides the most egregiously large, interesting shaped tower in San Francisco, which has a lot of commentary and some weird videos going on at the top there. For those of you who haven't seen it, it's interesting. Obviously known as a...
visit.
Sorry?
Everybody should come and visit.
It's got a beautiful park next door on
That's
top
right.
of the transit center, which I think is open again now.
It is.
We'll just do our tourist board moment for the city of San Francisco. But Salesforce, known for being the anti-client server software company way back in the day, one of the original giants, probably the giant of SaaS-based software. You've joined as an MD, a lot of experience at the VA and going back, I won't say a long time, how many years, but a few years in various other clinical roles. Tell us a bit about where Salesforce is taking its strategy. You're not an EMR, but you're kind of filling in around the gaps. Tell a bit more about that.
Yeah, so we've been helping people with their customer relationship management for 20 years now. We just had our 20-year birthday earlier this year. We've been in the healthcare and life sciences business for 20 years, believe it or not. But about 3 years ago, we decided to really invest in the healthcare strategy. And we wanted to move beyond just helping people sell their products more efficiently or sell their services. So we started a focused industry vertical with an industry product to build out and make it a little bit more comprehensive. So yes, you're right, we're not an EMR. That is not our intention to be the transaction layer of the healthcare system. We see ourselves more as the intelligent platform layer that surrounds everything that comes around the EMR. So with all of our core cloud offerings, we can bring together solutions that offer our patients and our members and the employees a better engagement platform. And I'm not sure if you guys have heard, but we made an acquisition last year into MuleSoft, which really bolsters our ability to have robust integration capabilities. So, the ability to have that and add on analytics. There's been more news, so we are really invested in adding, like I said, not just an engagement layer, now making it a much more interoperable, integrated, and intelligent engagement layer for our members and our patients.
And do you see the primary, and we're going to have a demo in a second here, but do you see the primary role for a Salesforce or a tool like that as, who do you think you're going to be helping? I mean, I'm sure anybody who'll buy it, but who do you think you're going to be helping, and where's the biggest bang for the buck instead of getting this interstitial part that's around the record and the data? Where are you seeing the most progress that's going to move the most quickly to get towards some of the claims?
So we're actually across 4 different subverticals in our business. We work with payers, providers, medical device companies, as well as pharma companies, and now working with genomics as well. But specific to this conference here, we're not an EMR company. We're also not a consumer company. We work behind the scenes as an enterprise company to work with companies like CVS and Aetna, work with government organizations and other provider organizations to ensure that all of the different sources of data that are come in into a single place so that you don't have to go between 7 or 8 different screens to provide the information that is needed when patients are calling in, whether it's calling into a contact center or calling in to ask questions about your disability benefits or other types of scheduling, et cetera. You can have all of those things in one place and help those kind of patients navigate the healthcare system with much more ease. We are essentially the digital front door for either a provider system or for payers when their members are calling in, particularly in this space, and I think we can help them. That's not to say that we are also not working with new entrants in healthcare like CVS or other companies. I'm not saying that we are, because I'm not allowed to, but if we were, we do work with new entrants like retail giants that are going into the space or other interesting types of companies. Perhaps, I've seen some interesting medical device and manufacturing companies that used to provide oxygen and other types of services, and now they've decided that they're going to get into home healthcare and do more, do direct patient services, or medical device companies that want to provide in-home dialysis. So we work with a lot of those types of companies to bridge the life sciences and healthcare to come together so that they can have the information that they need to take care of people as well. So, yeah.
Great. So joining us is your colleague, Minky Iora. Minky, are you ready to go?
Yes.
Fantastic. So I look forward to seeing, we're going to have a quick demo of what Salesforce is doing in healthcare now.
So this is just a really small sliver, but I thought this was important for us to talk about transitions in care. So this is a place where I find that patients are most vulnerable as they're getting discharged from the hospital and they're going into their outpatient setting. And here we have this demo through the eyes of Melinda, who is our case manager. She comes into her day, she opens up her desktop, and she notices that she has a notification for the day. She clicks on the notification, and she sees that she has a message from Carol Peterson, the discharging physician, letting her know that Charles, who is a known patient to Melinda and to Makana Healthcare System, is being discharged because he came in and had complications from diabetic ketoacidosis, and he's going to need some referrals to manage his care. And he has multiple comorbidities, and he's been assigned back to Melinda to help with this care. So Melinda says, this is great. Let me make sure that I actually have my referrals in place. She goes in, she checks on the referrals, and she ensures that indeed, when she checks her new referrals this week, she has 2 referrals for an endocrinologist and a nephrologist, as well as a medical rehab referral from Dr. Carol Peterson. So she goes in to check on the patient to ensure that he's in her system, and as you can see on the left-hand side here, there is information for the case manager that's coming in that's clinical and non-clinical from different systems, whether it's EMRs or billing systems or other sources of system that's all coming in into her one console. And she has an AI-enabled next best alert that's letting her know that Charles prefers to receive his communications and his educational materials by email. Now, he could have chosen his patient platform, he could have chosen his text messaging, but this is how he chooses. And this is important. Understanding patient preferences and how they opt to receive their information is really important to getting them to be more adherent and ultimately towards better outcomes. And then on the right side here, you see that Charles is actually a fairly engaged patient. He's already gone on and finished his Diabetes 101 Trail, which is an education course. Salesforce has invested in a learning management platform and incorporated this into our system to ensure that we can use this as a tool to help promote patient education. And it's called Trailhead. So he goes in, and she can see here, he's already done 101, so perhaps she can assign more educational materials because he's actually using it. So she goes in and also looks at his care plans. She wants to ensure that he has what he needs in his care plans and that he's actually making progress with the things that he's getting on. So he's actually closed off a few of them. He's got a few left. These are all things that have been assigned to him by different members of his care team. So Melinda checks in to see, does he have everybody that he needs as part of his care team? And she looks here and she sees a couple of new people have been added to his care team, and she can engage with all of them at once. Now, you see here, as part of the care team, she's got the referral physician, she's got the care coordinator, specialist, but she also has a couple of physicians in there. We often talk about physician burnout, so I just want to point out here that we don't have to directly message or engage physicians. These can have designates, so you can have a scheduler or a care coordinator or somebody, an office manager, who can designate the information for the case management portion of this. So she chooses to share an update with all of them. She can do it at once, she can do it just to one person, and let them know that Charles has indeed been discharged, he's getting scheduled for his diabetes education, he's going to have his appointments, and go on. So from this, we're going to move on back to the referring physician, Dr. Peterson. She can look at this as she logs into her workflow, whether it's through email, chatter, however she's been configured. And she sees that Melinda has closed the loop. She has made all of the appointments that was referred to her and has diabetes education in place. I just want to point out that she can receive this on her desktop, but as you can see here on the left-hand side, she can also receive notifications real time on her iPhone, on her mobile. And she can not only receive notifications, but on her mobile platform, she can also look at his care plans, reply back, engage, and continue to manage his care as she sees fit. So this is a really, really small sliver and a quick highlight, but the important piece that I wanted to mention here is, bringing on important collaboration tools, not just to physicians and patients through the portals, but to involve the entire care ecosystem, specifically case managers in this case, as they're helping with the transition of care, is really important and key, and providing them right tools will help with better patient experience, and really importantly, with better outcomes.
Thank you.
Yeah.
Awesome. So I think that sort of gives us a flavor, and we've now had these two. Thank you very much, Minky.
Thank you.
We've had two now demos of things of if you can get the right kind of data to the right people, you might actually improve the patient experience. And not very long ago, I stood there and said, we do a lousy job in the current system of managing people with chronic illness. I think everybody is now acknowledging that. There may be some people who think that we're still doing a good job in the US healthcare system. But I think most people are acknowledging that we spend a lot more money than other people. We don't do as well at managing chronic illness. So the question is, how much further do we have to go to get these kinds of systems into either from organizations like Salesforce, getting the right guidelines from the feds, and getting them into organizations like Aetna, CVS, and all your partners? I mean, where are we in that journey? So, Don, where do you think? Because, you're sort of setting the guidelines and seeing some of the rough with the smooth.
Yeah, I think the honest answer is we're relatively early in the process. And we're early in a couple things. Obviously, the standards, the FHIR standards, are a relatively recent. The underlying RESTful JSON, just the API concepts are really recent. People forget the original iPhone was locked down, right? You couldn't have apps.
Right.
And I think, so that part is new. Our specific rule will take effect 2 years after it is finalized in terms of, that's where it's looking at the moment. A lot of things are going to happen before then, truth be told. I'm certainly fine. We're fine if it is all done before the rule comes out. So, you've talked about Apple's Health Kit as an example of FHIR APIs. And I think the exciting thing, what we're seeing here from, what Ash just showed with Salesforce and Ben with CVS Aetna, is people are thinking about new pro-consumer business models. That is really what ONC and, frankly, the prior administration and absolutely this administration, what we're about is the consumer empowerment from new business models, new ways of looking at this. So I'm extraordinarily optimistic. It would be hard to imagine that the changes we've seen in the rest of our lives from this heavily networked technology are going to somehow keep escaping and not being in healthcare, right? It's sort of hard to imagine that modernity isn't going to creep into healthcare in terms of technology. It's just, I think it's going to come roaring in sooner rather than later.
Ben, one of the areas that I know you're sort of straddling this line, one of the areas that I raised in my keynote in India and I talked about, and I think is very clear, is that you've got a lot of complex patients out there with complex chronic ill needs. You've got a lot of consumers. I have the healthy people and the chronically ill. Yes, people go from one section to the other, and you have to deal with all of them. And there's a lot of different data needs, there's a lot of different services and processes, and and then we go on and on about how hard it is to get patients engaged with their health, even if they have a chronic illness, but let alone the health people, take me, the fat guy who should be going mountain biking more and doing more yoga and eating fewer cookies, but isn't a diabetic yet. Right. How are you thinking about both the services for these two sides of the street and the data needs and the information technology needs they have?
Yeah, great question. I think they are separate questions. In terms of the services, the thesis of institutional healthcare for the last couple decades has been bring the patient to healthcare.
Right.
It hasn't delivered extraordinary chronic condition outcomes and has escalated costs tremendously. The thesis, I think, of the Aetna-CVS combination in many ways can be summarized as flip that and take healthcare to where people are and make it local and convenient. And so I believe we're seeing investments by our company, and it'll take many others to change the entire system, but we've launched a health hub store concept with 3 stores in Houston that over the next 2 to 3 years will escalate to about 1,500 stores nationally. And a big part of the thesis is wrapping a chronic disease service wrapper around a retail experience, including Minute Clinic, pharmacy, DME, and counseling and support services in the store. And that's just very difficult to scale for any single player. And an institutional healthcare player will have a very difficult time prioritizing that investment over more beds in a local market that you can dominate. And so it's a business model problem that we're well positioned to exploit. The data question is another question, I think. I actually think in a rare case in healthcare, the data might get there before the services. In terms of the maturity of the industry, thanks in large part to the work you and others are doing with these standards and the policies that support them. And then the big question, as I alluded to earlier, in my view, will be healthcare institutions will have to decide if they want to make money from having data or make money from their use of data. And that will be a strategic choice that won't be imposed on them from day one from a policy perspective, but maybe over time, depending on the choice they make. I don't know. And let me give you a couple examples, right? One is exposing your encounter data to the patient as conveniently and accessibly as possible. 2 is embedding that data in workflow at an early stage in the point of care as possible, a Minute Clinic, a pharmacy, encounter. And 3 is commingling with patient consent that data with the data from your everyday life, like those generated by sensors, which Attain is a modest first step in that. There's a long way to go and a lot of room for a lot of players to contribute meaningfully there, and we don't estimate that we'll solve that unilaterally ourselves.
So Ash, I want you to take your Salesforce hat off for a minute and put your VA clinician, physician hat back on. This type of brave new world we're talking about sounds great. How do you think for the docs in the trenches who are suffering through the multiple clicks, how do you think they're feeling about this, and how do you think that patient population, that complex patient population you deal with, how do you think they're feeling?
I mean, look, this is really complicated, right? I mean, it's hard because this conversation is a lot more complex than just a simple response here, because it's not just about sharing data, it's about reimbursement rates, it's about the ability of systems to be able to provide the services, where access to care, right? This is a really complex conversation. I think you and I were talking yesterday, where I was telling you, I think we are expecting about 430 hospitals in rural areas to close over the next year. And that has like some serious implications to mortality rates in those populations, which means that we're going to become more and more dependent on probably companies like CVS and others to provide some of those interim services to ensure that people are getting better care in those, in those economies. So I think when you're talking about these things, one, I totally agree with Ben that we need to make sure that data is available to everybody. I think it makes clinicians really nervous because it's great that you're going to make data available, but there's a lot of data coming at us. When I'm in clinic, and I occasionally still do that, I get not only the EMR data, but I'm getting all sorts of data that's coming in from patient-generated data that people are bringing in. They're like, look at my FDA-cleared device. It's showing me these sort of things. How does this impact me? I've lost weight. I've done this. There's all sorts of data coming at you. And there's really no specific way for us there's no standard to say, this is how I'm going to incorporate this into the system, right? Or where do I put this into my EMR system to have it ingested and have it be part of the record so I can like transmit this on. And I think this is where we're going to need a lot more guidance and working together with Don and his team and others in government to work with us on, this is great, now we have EHR data, and we've been talking about it for years, but there are all these like new companies, new entrants coming in that are delivering care, that are providing data. What are we going to do with all of this patient-generated data, sensor data, et cetera, that's coming into the system? What are the standards for sharing these things? And what is the path ahead with that stuff? And I think that's really nerve-wracking as a clinician.
Don, you look like you want to say something about this?
I think Ash is spot on. We don't, for example, to emphasize, Internet of Things is wonderful, but we do not at the moment have standards to even ingest the data. Every device has a different formatting, and I think there's a great opportunity here for this audience and for large companies, small companies, to figure out how to actually pre-process it. Right? If Ash or I are sitting in the clinic, or Ben is working in the management team, there's too much data for us to do it real time without vast amounts of pre-processing and filtering. And this is on the flip side true for patients. The medical record is sort of, in some ways, undecipherable. Now, part we're actually in the administration solving by getting rid of the perverse incentives to do boilerplate cut and paste text that has no information in it to get a higher level billing code, right? I mean, the actual narrative is goofy, but there are going to, I think, be great opportunities to make sense of all of this for patients. We heard about next best step. Those kinds of things are going to be happening, I think, in spades, and that's going to determine the people who do it well will be the winners.
Fantastic. Okay, we're going to flip a little bit, do another of the big, bold moves. There's a teeny company that some of you may have run into and been on hold with called Comcast that has cable boxes all across the nation, including one backstage in a very complex way. And they've been working with one of the big Blues plans, Independence Blue Cross in the Philadelphia, Pennsylvania region, to come together. And this is Carina Edwards, who's the CEO of Quil, a new joint venture in which she has to fend off those two giants and make sure her team does okay as an independent new company. So Quil is a digital health platform taking advantage of all those different resources with the goal of helping individuals and their caregivers organize and navigate their healthcare lives. And Carina's here with her colleague Jason Gresh to show us how that works and what it looks like in reality. So Carina, take it away.
Thank you. Good morning, everyone. Thrilled to be here. Okay, so in this example, we're going to do a quick demo of the Quil patient engagement app. And in this example, I'm a patient. I'm going to have my knee replaced in about 3 weeks, and my doctor has prescribed Quil as part of my care plan to prepare myself. And so what you'll notice on the phone, my smartphone, the doctor's office has just reached out to me, and they've asked me, where are you on your pain today? And they want me to go right into the app, so we'll swipe into the app, and it brings me right to the to-do section, right to the pain scale. And today, after that 6.5-hour plane ride from the East Coast, my knee is killing me, so I'm going to log a 7. And so we quickly log that. That information goes back to the provider, right? So the provider has the telemetry of what's going on with me every day. But now I'm also back into my to-do section. And so when you think about the to-do section of the Quil app, we're really thinking about how do we make sure we answer for that patient, as we go through here quickly, some articles that I need to do as part of my care plan. So here, preparing before surgery. This one looks like a long one, and I'm not going to read it in front of 500 people, so I'm going to remind myself to do this one tomorrow, and that nudge will come back up and engage me. We can also do other things on the app. We can have some fun with our patients and their caregivers. We can prepare them with quick quizzes and quick information. So here's one. Exercises before surgery can improve recovery. True or false? Oh God, my knee has been killing me. There is no way I want to exercise before surgery. So I'm going to hit false. And it's going to tell me, yeah, no, sorry. You really have to get moving to get your leg prepared for the upcoming surgery. So on that, my next to-do, shockingly personalized for me, is going to be my ankle pump videos. And I really don't like doing these on a phone or a tablet. So we brought the TV into the equation. So I'm going to go to my living room, walk this way over to the living room. I'm going to grab my remote control. 30 million people have one of these remote controls in their house. And I'm going to say Quil Health. And this Quil Health app, so this is a live actual bringing a cable box to a convention center, a live TV projection of the Quil Health app. And this is just like when you go and do your Netflix or your Amazon Prime and you navigate that box, or an app on the box. And now with this, though, this is generic. So today there are 150 plus videos up here that NBC Universal has helped me build to really talk about health and wellness. But now I need to do my personal care plan. So we're going to bring up the two screens. We're going to show the phone and the cable box. And with a one-time token, I'm going to activate the cable box to be my personal care plan. So now that same to-do list that we had on the phone is going to be brought right to your living room. So you can literally sit there, connect, and the ankle pump videos are there that we can do in our living room.
Carina, you're not getting away with this. You have to do the ankle pump. Come on.
Okay. So let's play the ankle pumps. Quil, playing ankle pumps. Now imagine you're all in your living room. All this is good for plane rides too, right? So we should all do our ankle pumps before we get on the plane. And so that's an example of how the videos play. But more importantly, and I'll leave you with this, when you're thinking about your care and engaging that care team, the most important thing you can do is also have those hard conversations, right? We're thinking about who's going to take you. How do you actually sit down in your living room, talk about home recovery and preparing the home to make sure everything's there for you? How do you make sure that you know who's going to care for your incision and help you along the way, and how do you share that information to them? We believe Quil is here to bridge that gap, really empower patients and their care teams to know what to do next in their care plan. So thank you. That was our demo. Thanks, Jason.
Thank you, Jason. So we have a couple of minutes left to discuss this. We've kind of gone during this panel across a panoply of complex technical data sharing through to us as the consumer who needs to lose the 20 pounds, or maybe it's 25 pounds, I don't know, in my case, doing their ankle pumps and doing surgery. Actually, funnily enough, one of the winners of the RWJF challenge yesterday was something called prehab, which was doing prehabilitation. Yeah. It's exactly what we need. So that can be on the Quil channel. Carina, with Quil, two big companies come together, do this. They obviously see healthcare as an opportunity, much as many other we've been discussing. And obviously, the cable box to TV hasn't really been involved to this point so much, right? So I get the very interesting integration where, and it worked, right? I don't know, this was quite the demo from the demo, attempt of the demo gods, because apparently if Comcast sends out a signal to, they think you're stealing cable.
To 500 people, yes.
But make it work. As an organization, you're a small company.
Yep.
How are you trying to spread this, and who ends up using this? Where does it fit in a world in which you have a CVS and you have all the different players that Salesforce is playing with? Where do you go?
No, it's a great question. So we are a B2B2C organization. So today we are selling B2B. We sell to provider organizations, we sell to payer organizations and self-insured employers. And then they give the service and prescribe the service as part of their care plan or member engagement strategies. But the beautiful thing is, we're not just that one-size-fits-all, here are the conditions we cover. We're actually a content management workflow system, and we can actually put any content and any logo, and we can film the docs in the practice. So it's your doctor talking to you and seeing it in a sequence that they want you to be able to complete. But also, more importantly, it knows me. So when I log onto the Quil app, I do a couple things. I talk about my goals. And my goals are very different if I'm doing a knee replacement. I'm getting back to the golf course in 10 weeks. If I was a 72-year-old grandmother who wanted to walk a flight of stairs and play with their kids, I'll show them different imagery different content all in the app because I know them and I know what their goals are.
Yeah, I think there's and again, this is touched on before, and we're seeing a lot of it, which is the whole goal of this data that wasn't really in the healthcare systems coming in the healthcare system. I think all of us have got to play with that, right? Which is, and you've got it there. So when you're you got a message from your doctor.
Yeah.
There's an integration there somewhere in the doctor's workflow. How does that bit fit? Does that fit with a Salesforce? Where do you start and where does that stop? In terms of getting data all the way from, we started this panel with data from Medicare, which may be relevant and coming through about knee replacement. So where do you play?
Yeah, so it's interesting. So we actually will be a consumer of that data. So leveraging Blue Button data, leveraging some of the FHIR interfaces and bringing that information in. And we'll also then be giving the providers back the data. So if they want to integrate it into Salesforce, or they want to integrate it into their member systems and their payer systems. So we have a data layer to the platform, and it ingests and then it personalizes all of the algorithms. So we do decision logic. We do a little bit, I don't want to go too far into the AI machine learning and use the overkill buzzwords, but right now we're able to do a lot of customization just based on the simple things about you. Your BMI, are you a smoker? Are you diabetic? Do you have hypertension? I can weave in different little things before a surgical encounter or before an episode that can help someone, just nudge them to change their life a little bit.
Ben, this sounds to me as though it's the same sort of consumer-facing place that you're taking at a CVS. Obviously, there's going to be competition. Did you expect you were going to get competition from a cable company, a health plan? I mean, obviously, Independence and Aetna, are rivals in some extent. But as you mentioned, there's going to be a lot of different players in this role. Where do you think that the center of managing these patients resides? Does it reside with the patients themselves and consumer organizations like a Comcast, or is it going to manage all the plans? How do you people think about that internally at Aetna?
Wonderful question.
To which you have the answer.
The history, history suggests that the institutions of healthcare, whether they're vested with that duty or not, haven't done a great job. Now, I don't know that just saying let someone else do it means they'll do it better. But I think there is abundant room. If a patient wants to spend time in front of their TV and you can deliver a great content experience for them that translates to a good health outcome for them, why should we say, no, that's not the right channel, right? I think what you're doing is brilliant in that way. And if you are only making money selling services, that could be viewed as very threatening. But if you can actually make money off of better health, you should be embracing that and saying, let's work together, let's help each other. So I think it's foolhardy to say, we'll pick one channel and that's the one that 20 million people have to engage with to improve their health. You're not going to hit everyone in that mindset.
Yeah, I agree.
Ash, you're looking at me quizzically, and I think that the question here is, how is it for your tech service provider who's going to help integrate lots of different data sources, is this just another? How do you figure this out? Are you going to find that providers are going to be asking for their Quil channel or their other consumer channel? How is this playing the way you strategically plan for what you're doing and what you're not doing? Because in the end, big tech companies like a Salesforce, or for that matter, an Amazon or a Google or whomever, they have to decide which bits they do and which bits they don't do.
Again, good question. I just want to quickly go back to what you were just saying. I think the burden no longer is just on the hospitals or the providers to take ownership of this. Specifically, what we've seen at Salesforce, because we work across different industries, is the rise of consumerism is leading to more engaged people. It's the same people that are getting care, that are also buying on Amazon, that are ordering their Ubers, that are getting amazing experiences in restaurants, and they want the same level of experience. They want their data. They want to have it at hand. They want to share it with whomever they want. They want to be able to use it however they want, whether they go in and work with Comcast and have this stuff, or whether they go into a local retail clinic. And Salesforce will work with all of those different partners to enable that. I mean, we do work with providers that say, we want you to integrate with this EMR, and we want you to integrate with Apple and with Comcast. The providers and people are going into their provider systems and saying, here's the stuff that I'm using, I need you to put into it. And in turn, providers are coming to us as we work with them to say, we need you to integrate across all of these systems and bring all of that information together in one place so that we can make it useful. And I think, like I said earlier, bringing on MuleSoft to add to the integration layer for us, to allow for those integration systems to orchestrate those things and to push out standards-based API formats and to work within those systems. We are committed to it, and we will work with any partner. We are not, we're not a B2C company.
Let me push you a bit on that,
Yeah.
because part of the thing when Indy started this morning talking about, the name Salesforce didn't come up, but you are a tech giant. You're not quite the scale of the Amazons or the Apples,
Yes.
but that's, or a Google. They start off as looks like a neutral platform, and they've all been criticized, both politically now and also by several other businesses for sort of pushing their own interests. The EU is getting involved in this, and Elizabeth Warren's talking about it. Is it not a business temptation for a Salesforce to go, well, if somebody wants something like a Quil, instead of using a small company like a Quil, happens to be a small company owned by two big companies, we can do it ourselves and promote that instead. Do you think that is something that is on the radar, something you're going to have to be worried about in healthcare? And maybe the same thing's true for an Aetna and CVS.
I mean, of course, there are going to be areas that we're going to take on, and we will go into those. We have industry blueprints across all of our subverticals that we release every year. This is, publicly consumed. We share it with our partners. So if we're going to be working with a company like Comcast or Quil, we let them know where we're going over the next year or two. So if we are going to enter a space that we're going to be competitive, there's plenty of warning to say we'll work together for X period of time before we enter the space. I mean, I'm not one to say that we will never enter the healthcare space. I think there's lots of opportunities for us to do so, but healthcare is a massive market, as you know, with like an amazing number of use cases. So for Salesforce or Amazon or Google or any one company to say that we're going to go in and take over all of healthcare is just unreasonable. I think it's going to require an entire ecosystem for us to provide the types of services we're talking about. So.
We don't have anyone from Optum on the stage, so I don't know if that answer would change. But Ben, a quick word about how you're thinking about this from Aetna CVS.
I agree wholeheartedly. Our company is a very large-scale company, and we have a lot of wherewithal to do a lot of stuff. But to win in this last mile, the experience has to be awesome for the user. And for the experience to be awesome for the user, it's incumbent on companies like ours to disentangle a big, huge mess between the time the data is generated, the service delivered and paid for, and the way the consumer engages. And frankly, it consumes a ton of bandwidth to untangle that big mess, and we don't have the ability to untangle all the messes. So we need partners.
Fantastic.
Yeah.
And Don, final word from you. The mess to be untangled in our lifetime, or is it going to take longer than that?
Well, it's interesting. I think it is untangling itself in a very subtle way, which is the basic root problem here is that most healthcare is paid for by third parties, and all of the sort of moral hazard issues there. More and more is coming directly out of the consumer pocketbook. Right now, it's for employees, it is roughly 50%. As that increases, the entire set of incentives changes. People are going to be empowered and are going to demand to look for new solutions. Part of what I think is also going to happen is you're going to see a shift from acute care to prevention, right? Because why do we have acute care without prevention in the U.S.? The main reason is because since World War II, we have the employer insurance as a pre-tax product. This pre-tax employer insurance is a one-year gig, right? That's just the way it's been in the U.S. You wouldn't invest in any long-term activity like a mortgage or a car loan or most insurance lines on a one-year basis. So as more and more comes back out of our pocket directly as opposed to indirectly, we're going to have the chance to think in much longer time horizons. And the whole nature of the game and the consumer equation is going to change from that economics. It's happening very subtly. It's happening under the covers. It's not a policy thing. Nobody's really talking about it. It's going to be a rough journey. But I think that fundamental force underneath is going to change the entire equation of U.S. care delivery.
Fantastic. And with that, we're done with our panel. I want to thank Carina, Ash, Ben, and Don for joining me.
Thank you.
A round of applause.